Good afternoon. Thank you all so much for joining for today's wonderful Wednesday, the many faces of acute kidney injury. I'm Barbara McLean. I'm a critical care clinical specialist here at Grady Memorial Hospital in Atlanta, Georgia. And today is election day. So thank you all for voting. If you haven't voted yet, get off of this call and go vote, my friends. But today I want to talk about the many faces of acute kidney injury. So first and foremost, we always have to start off with just a basic review of the structure and the function of the functional unit of the kidney, of which there are 2 million, and that is the nephron, 1 million per kidney. Each one is composed of a very significant functional apparatus. The first apparatus is the glomerular filter, and that accepts arterialized, dirty, dilute, and electrolyte-rich blood. That blood comes in based on volume and pressure, or flow and pressure, pushing, filtration, filtering to equality, water, solutes, electrolytes, acids, buffers, all being filtered here, dropping into the bowl of the Bowman's capsule and going down into what we call the tubules. That blood that enters into the glomerulus, filter, leaves the glomerulus. It's still oxygenated, still arterialized blood. And from here, we'll differentiate into what is called the peritubular capillaries, which will surround the tubules of the kidney, setting up an interface for reabsorption of solutes and water that we need in the blood, and for secretion of solutes and water that we don't want to have in the blood. What's really important to remember is the glomerulus is an indiscriminate filter. It filters everything. The tubules are responsible for the concentration or dilution of urine. The glomerulus is dependent on blood flow and blood pressure, but it does not consume much oxygen. The tubules, however, are blood flow and oxygen dependent. Now, because the kidneys are a primary blood flow and blood pressure organ, the kidneys receive about 20% of the cardiac output. So if your normal cardiac output is 5 liters, then 20% is a whole full liter of blood flow per minute, filtering. The filtrate gives us particles and water, solutes, and electrolytes, and then the exiting artery, the efferent arteriole, will divide into peritubular capillaries where reabsorption and secretion will take place. So in order for this to happen, in order for the kidney to keep your blood perfect, electrolytes perfect, water perfect, acid and buffer perfect, all those things that are required of the kidneys, so many beyond even what we can mention, you have something known as autoregulation. Autoregulation means that with a very wide range of MAP, typically around 80 to 160, MAP 80 to 160, you will retain and assure appropriate renal blood flow, or appropriate renal blood pressure, and appropriate oxygen delivery. So really, really important for us to appreciate and understand that, because this is what actually helps us to determine what we'd like to do. Now, most of us work in an ICU where our order sets say, keep your MAP above 65, and that's well and good. It is primarily the understanding of nephrologists and people who are interested in critical care nephrology and kidney function that the kidneys actually need a little bit higher MAP to maintain their normal function. That doesn't mean you're going to go back to your hospital or your unit and change what the MAP goal is, but it is important to appreciate that when you note that kidneys are at risk in a patient with cardiogenic shock or hypovolemic shock, hemorrhagic shock, or septic shock, you may need to drive an MAP that's a little bit higher in order to protect the kidney. Now, this is very complex. Renal blood flow autoregulation, the way it regulates the volume and pressure going through the glomerulus and the delivery of oxygen at the tubules, is very complex. So it's not solely dependent on that MAP. There are many other factors. But what I want you to remember is that every time your blood flow changes below or above autoregulation, a little bit more injury to the kidney can occur. And this is of great concern to us, because the kidney, of course, is really the center of the homeostatic universe. We don't think about it that way, but it's such an incredibly important organ in terms of managing all the other organs and communicating with all the other organs and regulating volume and regulating the electrolytes, which of course, all of our cardiac depolarization, repolarization, contraction, relaxation, neurologic transmission, all dependent on the regulation of our ions, and that depends on the kidney. So this little simple drawing, it's my drawing, that's why it's so simple, is just to remind you that on the aortic side, the aorta divides to the renal arteries go into the afferent arterioles on the aortic side, that's what the A is, carrying blood filled with waste, filled with water, electrolyte rich. That blood enters into the glomerulus and you filter, separating product and water from the oncotic and osmotic pressures and filtering everything that was pushed out that descends now into the tubules. Exiting the glomerulus is the efferent arteriole, and that is carrying the filtered blood. So that blood is much cleaner. It's more concentrated. It's electrolyte depleted, but it's still oxygenated. That efferent arteriole gives rise to the peritubular capillaries, which actually set up an interface with the tubules, reabsorbing that which we need back into the blood and secreting that which we don't into the tubule. And it does that through a very particular interface, which is an oxygen-dependent interface, and that's really called the brush border of the tubules. And that border allows for electrolytes and other particles to pass freely back and forth based on concentration gradients. More particles to less particles, more water to less water. That's what really occurs, is basic osmosis and convection. Osmosis, solutes from greater concentration to a lower concentration, and convection, water from more dilute to less dilute. And water always drags along other solutes. Now, I want to remind you here, this part, the glomerulus, is volume and pressure driven. And this part, the tubules, is blood flow and oxygen dependent driven. So it's really important to remember that one of the most critical issues is recognizing when we have a reduction in renal blood flow and in renal pressure, because that is going to put the tubules at risk. And once the tubules are at risk, remember they're oxygen dependent. Once they infarct, that is not necessarily recoverable. So we always remind ourselves, and I talk about this a lot, the role of the kidney is to keep your blood perfect. Perfect blood allows you to have depolarization, repolarization, contraction, relaxation, vascular tone, normal functions. Anything that depends on ionic concentration depends on the kidney. The kidney is responsible for the regulation of water and electrolytes. All of us know that. But it's also really important to remember that the kidney is responsible for the regulation of acid-base balance, and that the higher presence of acid, that's the hydrogen ion, we evaluate that because we see a low bicarb or a base deficit. Whenever we have metabolic acidosis, that's going to profoundly affect our vascular tone, the ability to manage blood pressure. If we can't manage our blood pressure, why, we will then further injure the kidney. 20 minutes is about how long the kidney can sustain in a hypotensive state. Beyond that, you start to have significant kidney injury. Now, we are all very aware kidney is responsible for excreting metabolic waste. It's responsible for excreting foreign chemicals, that's excretion, but also secretion. And the hormones that are primarily and significantly impactful from a kidney perspective are the number one hormone that the kidney produces. Kidney produces in the afferent, primarily in the afferent arteriole, in a little apparatus that resides right here. It's known as the next to the glomerulus or juxtaglomerular apparatus, referred to as the JG apparatus. That has a baroreceptor, and that baroreceptor is responsible for the release of renin. Renin then travels in the blood till it reaches the venous circulation and is dumped into or delivered into the portal venous circulation. So renin traveling via the portal venous circulation will meet up with an enzyme or hormone enzyme that's released from the liver, and that enzyme is angiotensinogen. Angiotensinogen plus renin converts to angiotensin 1, and angiotensin 1 travels in the blood to the lung where it's converted to angiotensin II. Now, this is really important because angiotensinogen by renin, creating angiotensin I and then angiotensin II, is the most potent vasoconstrictor known to man and is not dependent on the stability of electrolytes intracellular at the receptor sites. And that electrolyte would be potassium. So what we want to remember is that when we have somebody with acute kidney injury, what goes hand in hand with that is metabolic acidosis. What goes hand in hand with metabolic acidosis is the metabolic acid hydrogen enters into the cell and the cell releases potassium, but the cell cannot depolarize with the high presence of hydrogen. It'll only depolarize with the presence of potassium. So you lose your vascular tone. You've lost your vascular tone, then the volume and pressure driving flow into the glomerulus is reduced. And if the volume and pressure driving flow into the glomerulus is reduced, the blood flow delivering oxygen to the tubules is reduced. Oh my gosh. Who thinks about that? All you're thinking about is, how do I get that blood pressure up? And I'm titrating up and up and up. But if we step back and we say our patient has refractory metabolic acidosis, check. And if they have acute kidney injury, what we also know is they have an increase in renin as a response to the poor blood flow and pressure, but that renin never really reaches, or the abundance of renin never really reaches the liver for conversion by the marriage to angiotensinogen into angiotensin, which means that now you've also lost that potential to maintain your blood pressure. Just as a reminder, we give exogenous angiotensin II as Giapreza, the most potent vasoconstrictor known to man, 10 times more potent than norepinephrine. And norepinephrine is 10 times more potent than, say, dopamine. So this is a really potent agent. And recent studies show that with patients with AKI, acute kidney injury, they have a high circulating renin, but a low circulating angiotensin II. What does that mean to you? It means when you have acute kidney injury and you have hypotension, stop titrating up on norepinephrine and epinephrine. Have a discussion with your pharmacist about the role of angiotensin II for this patient. It may not be right, but it could be, and it may save your patient's life. So it's really important for us to have that discussion. Okay. Now, from an epidemiologic perspective, we just say acute kidney injury is a sudden impairment of kidney function that happens over hours to days. Patients who admit to the ECC with severe sepsis, or what we now would call septic shock, they've already lost 50% of kidney function, and they've just come into your hospital. AKI is present in 7% of all patients, but up to 30%, and probably in my practice, probably about 40% of patients in the ICU. If you require dialysis, either continuous renal replacement or hemodialysis, the mortality rate of these patients increases to above 50%. Now, let's be sure we don't confuse that. It's not mortality from dialysis or from CRT. It's comorbidity because we didn't identify our patients soon enough. We didn't protect the kidney, and the kidney communicates disorder to all of our other organs. Most patients who receive dialysis, either, again, CRT or hemodialysis, about 25% of them actually do not progress to recovery, but progress to end-stage renal disease within about 3 years. What that means is they're getting hemodialysis 3 times a week, and they're on the kidney transplant list. So really important to understand acute kidney injury within the clinical context of critical care and critical illness. Now, it's very important to remind ourselves that the kidney has a lot of opportunity to preserve its own function. That's what we call autoregulation, right? And when we talk about that preservation of function, when blood flow decreases for short periods of time, the kidney can autoregulate, maintain its function, reduce the oxygen-dependent component, which is the tubular function, can reduce that oxygen-dependent component to preserve the kidney, but only for short periods of time. And typically, what we're going to say is less than 20 minutes. That means that 20 minutes, 30 minutes, 40 minutes, 50 minutes of hypotension, you are almost 100% certain that you're going to have kidney injury. So I want to remind you, the kidney is a very high flow organ. It requires a lot of blood volume and a relative amount of blood pressure. It only requires Out of that 20% of cardiac output, only 10% is actually delivered to the tubules, but the tubules themselves require 80% of the total renal oxygen. Okay, so let's reconfirm what I've just said. Blood flow is what is absolutely essential for the maintenance of glomerular function. And that blood flow ends up delivering oxygen to the renal tubules, and the tubules consume 80% of the available oxygen delivered to the kidney. So any episode of renal reduction of flow or of kidney hypoxia is going to significantly alter our tubular function. And then that tends not to be recoverable. So that's really important. Any interruption, kidney blood flow and pressure, can lead to a significant reduction in tissue oxygenation. So very important to appreciate that once the kidney has suffered an injury, and it may not even be an injury that you're diagnosing necessarily at the beginning, first and foremost, the kidney is going to release thousands of different uremic toxins, thousands of them. We're going to measure some as metabolic waste in the serum and metabolic waste in the urine, right? Metabolic waste in the serum, and metabolic acid in the serum. So we're going to look at BUN, we're going to look at creatinine, and we're going to look at base deficit or low bicarb. Those are going to be really important for us. But we've already released thousands of uremic toxins. Those uremic toxins create a stimulation in the sympathetic nervous system, and the sympathetic nervous system causes a further reduction in volume to the kidney, which then supports more uremic toxins. Oh my God, it's a catch-22. Got to stop it somewhere, and that really is going to be by recognizing patients at risk for AKI. Another thing that happens when you have an injured kidney is the release of inflammatory mediators, and also because of some failure of the tubules, you're not really able to concentrate and dilute urine appropriately, so you typically end up in a volume overload state. That volume overload state is venous volume overload, not arterial volume overload. So I have venous congestion. My CVP is up, my neck veins are distended, I'm gaining weight, I'm swollen like the Michelin Man, but I don't have good renal blood flow because that's venous volume and interstitial volume, but not arterial volume. And when I don't have arterial volume, that stimulates the activation of the renin-angiotensin-aldosterone system. That is the RAAS. Don't confuse that with RASS, which is your sedation scoring tool. This is renin-angiotensin-aldosterone system. That release, whatever blood flow is going through the kidney, that's going to stimulate the reabsorption of sodium and water, and it stimulates, hopefully, the terminal point of angiotensin 2, which is a potent vasoconstrictor, which in and of itself stimulates more aldosterone. It's complicated. It's complicated. This is why you have to have a specialist for this to really understand how complex this is and what's occurring. As I overload with fluid, I'm going to stretch my vessels. And as I stretch my vessels, I'm going to lose the barrier of the endothelium. That's known as the glycocalyx. Fluid is going to shift out into the interstitium because I no longer have a good barrier in my vessels. And ultimately, I'm going to have some epithelial injury, which will in turn stimulate hypercoagulation, a whole series of other events. So it isn't just as simple as saying, oh, look, your creatinine's okay. No, you've got refractory acidosis. Always think kidney failure. You're gaining weight. It's not from the great food you're getting in the ICU. You're gaining weight from fluid, and that fluid's in the interstitium. Fluid's in the interstitium and fluid's in the veins. It's not in the arteries. And the only important place for fluid is in the arteries because that's what's going to promote the delivery of oxygen to the endpoint cell. So what kinds of things that put the kidney at risk? I'm pretty sure you understand by now, anything that affects blood flow and pressure is going to put your kidney at risk. So really, really important when we're thinking about the three phases of acute kidney injury, we consider the three basic types. I'm not going to go into every type. I want to talk about the type that we should be paying attention to as the bedside nurse who's giving fluid and titrating vasopressors and watching what's happening to the patient. We're going to focus on the condition that promotes glomerular dysfunction, and that is the primary condition is pre-renal, meaning something before the kidney has affected volume and pressure, maintaining renal blood flow. So this is a circulatory issue. It's a vascular tonal issue. It's a volume issue. So cardiogenic shock, septic shock, distributive shock, hypovolemic shock, hemorrhagic shock are all prerenal conditions that put your kidney at risk because of a reduction in blood flow and pressure, which then reduces the oxygen delivery to the tubules, which are highly oxygen dependent. The kidney as an organ is not oxygen dependent. The tubules of the nephrons are highly oxygen dependent. So AKI is basically evaluated when we're thinking about our patients. When we are considering our patients, we just think about AKI is very important. And what I want you to appreciate, because you're not the physician, you're not writing the orders, but you are the person at the bedside. In the first 48 hours under your care, when we see your creatinine has increased at least 0.3 milligrams per deciliter in the first 48 hours, you already have an acute kidney injury. If you're with me for 7 days, I'm going to look for a 50% increase in the baseline creatinine. So you came in at 0.8. At 1.1, you already have acute kidney injury. At 1.2, you have a significant injury that just took a little more time to flower and present. And we're going to correlate that with urine output that is measured as a weight-based measure averaged over time. So by the way, urine output every hour, religiously documented every hour. Then I look at a 6-hour time period. I add up all the urine in that 6 hours, and I look at the average urine output over those 6 hours. So the average urine output divided by 6 tells me how much you made per hour in an average. I then divide that by your weight in kilograms, and adults should have urine output greater than 0.5 mLs per kilogram per hour, and typically less than 1.5 mLs per kilogram per hour. If they're not meeting that, if they're way above or way below, and they've had an increase in serum creatinine, they deserve an evaluation. Now, you may not be able to ask for a nephrology consult. You're going to ask your team to evaluate the patient, depending on how much they know and love the kidney and how much they're aware of these kinds of indicators will determine whether or not they're going to look at what's happening with the kidney and try to restore blood volume and pressure. But you're going to be a gnat about this. You're going to fight for this kidney, for this patient, for this kidney, for the preservation of their quality of life, and for the reduction of morbidity, even though it is relatively the shyest organ in the box. And most of us don't really notice anything until you're not making urine and your creatinine is tripled. We got to stop that because we got to look at it in a much earlier presentation. Okay, so my focus really is on prerenal AKI, although there are 3 phases: prerenal, intrarenal, and postrenal, and they're all really important. Don't misunderstand me, they are. But the one I think we're missing is prerenal, which is impaired perfusion because of sepsis, because of dehydration, because of occlusion of clots, renal thrombi, because of cardiogenic shock or cardiac failure. Many reasons that reduce the blood volume and pressure that enter into our glomerulus, okay? So really thinking about the loss of effective circulatory blood volume or the loss of overall volume and how we should be characterizing that as a primary condition in critical care that puts the kidney at risk. And that's the face of kidney injury and kidney failure that I really like to talk the most about. Okay, so if I focus on phase one, I just want to remember that prerenal dysfunction is really hypoperfusion of the kidney. And that's from arterial hypovolemia, systemic vasodilation, and also vasoconstriction. And arterial hypovolemia means I might have volume, it's not in the arteries because I have heart failure. I might have volume, it's not in the arteries, it's all in the veins and the interstitium because I have cardiogenic shock. Or I might not have volume, I'm hypovolemic, I've been urinating, I was in DKA, I was in DI, I urinated all my volume out, and now my kidneys are hypoperfused. Really important to look at the context. The context here is critically important because the treatment of prerenal kidney injury is to treat the prerenal problem, not just to react to blood pressure, but to treat the problem and to try to ensure that you have appropriate arterial volume and appropriate arterial pressure secondary to that arterial volume in order to restore renal perfusion. So it's very important for us to understand that the first sign is a failure of filtration. We can see that in your glomerular filtration rate. We see that in your urine output. We see that because first and foremost, your BUN goes up aggressively and your creatinine goes up mildly. Now, BUN is not a reliable indicator, but it does go up aggressively in prerenal dysfunction. Now, for a period of time, the kidney is going to adapt. It's going to adapt through renin-angiotensin-aldosterone stimulation. It's going to adapt through sympathetic nervous system stimulation. But if this is sustained, you're going to start to see loss of kidney function. Now, I want to remind you that if I have sustained hypoperfusion of the glomerulus, I'm going to end up infarcting my tubules, and that's known as ischemic acute tubular necrosis. Didn't have adequate delivery of blood volume or blood flow, inadequate oxygen delivery, inadequate nutrient delivery, and I deplete the energy stores. Those energy stores are 3 bonds of phosphate on an adenosine molecule. No one cares. What we care about is that you have to have energy stores to regulate function at the renal tubules, because at the renal tubules, you're going to reabsorb solutes and water against current. That's known as countercurrent. That always requires energy. And once you deplete that energy, you're going to infarct the tubules of the kidney. So this is a really important perspective. This happens fast. It happens anytime you have a relative arterial hypovolemia or loss of vascular tone. So for me, I certainly want to give you volume if I think you're volume depleted, but my biggest issue will be mild vasoconstriction and mild inotropic support, because I want to assure that you have appropriate arterial volume. So I might give you a volume challenge, but then I got to move that volume, and I'm going to do that with inotropic support. And I want to maintain your renal perfusion pressure, and I'm going to do that by adjusting your MAP using vasoconstrictors. So I want to just remind you that in the very beginning, GFR, reduction in GFR, glomerular filtration rate, and reduction in urine output are really the gold standards, and they're easy for us to look at. GFR comes back on every chemistry you do, and almost all the patients that I look at in terms of case study analysis on early evaluation in the emergency department and introduction to the ICU, they almost always have a GFR that's almost non-survivable. So just remember, GFR for Caucasians is 80 to 120. We're going to lower that a little bit because of muscle mass that's really related to persons of color, particularly. We're going to lower that lower number to about 60. So what that means is anybody with a GFR less than 60 is a person at risk. People who have a GFR of less than 40, they're at incredible risk. You should be paying attention to GFR. That's a fantastic indicator of whether or not you have resuscitated arterial volume. So my patient comes in, he has a GFR of 15. I give him 2 liters of fluid. His GFR goes up to 70. But now we start to see that he's got some cardiac dysfunction and his GFR drops down to 20. And then you put him on a vasopressor and his GFR drops to 15. That's because you didn't actually pay attention to arterial volume and arterial flow. And that is what you need to do when you're treating patients who have prerenal dysfunctions. So any state of a diminished cardiac output, that would be hypovolemia or hemorrhage, distributive shock, loss of vascular tone, and cardiogenic shock, which is about loss of myocardial efficiency. This actually is going to put your patient at risk for acute kidney injury. And not over 3 days. It's going to start happening within an hour. But you're not going to see output from that for probably 12 to 24 hours. And if you're not paying attention, you're not looking at it, saying your creatinine is increased 0.3, you're waiting for it to go above 2, or you're waiting for it to go above 4, you've just signed the kidney to a lifetime of dysfunction. And that's not okay for us. We need to really be thinking about these states of diminished cardiac output and what we want to do. So that brings me to the point that prerenal dysfunction is like unstable angina to the heart or TI, transient ischemic attack to the brain. It's a warning. Pay attention. That's your job. Pay attention. It's a warning that you have a kidney that is being injured, right? Remember, with that initial hypoperfusion, the kidney will adapt, but if it's sustained, it's not noticed, it's not treated, we start to infarct the tubules, we have endothelial injury, now we have an inflammatory response and further activation of renal dysfunction and renal damage. So again, just to remind you here, your brain can sustain a reduction in blood flow for less than 3 minutes without having brain ischemia and brain infarct. The kidney and the liver, about 15 to 20 minutes. The skeletal muscle, around 60 to 90 minutes. The heart is right in here, about 5 minutes. skeletal muscle is 60 to 90, and vascular smooth muscle much longer. 20 minutes. 20 minutes of hypoperfusion. Hypoperfusion, remember, is not hypotension. Hypoperfusion means a reduction in arterial blood flow to the kidney. And we don't necessarily know that that has happened, but we're watching our patients very assertively, very aggressively. So now we talk about the kidney that is hypoperfused and hypoxic. Low blood flow and pressure entering into the afferent arteriole, reducing glomerular filtration, which means less filtrate and less urine. Also, reducing the filtering of the very prevalent blood urea nitrogen. And so BUN starts to go up, and we're seeing that the patient is going to have a significant reduction in urine output. Exiting, so the blood enters dirty, dilute, electrolyte rich, and oxygenated, exits dirty, dilute, and electrolyte rich and oxygenated. And what actually happens is, because you have less filtrate here and you have less blood flow here, you're not reabsorbing what you need. So things like sodium are going to be lower. You're not reabsorbing bicarbonate, so your acidosis is going to get worse. You're not secreting from blood to filtrate. You're not secreting metabolic acid. You're not secreting creatinine. So in your blood, the acid is going to get worse and worse and worse, and the creatinine is going to get higher and higher and higher, and you're barely utilizing any oxygen, but you didn't have much oxygen to begin with. Now, I want to just make sure everyone is appreciating what I'm saying here, because one of the most, I think probably one of the most important evolutions, if it pans out, will be actually looking at external evaluation of renal oxygenation. Because when you see that renal oxygenation is inadequate, you know that your tubules are going to be at risk. So this is a really important perspective. Your blood entered dirty, dilute, electrolyte rich, and oxygenated, and it leaves dirty, dilute, electrolyte rich, and oxygenated. Should have left clean, relatively concentrated, electrolyte perfect, and deoxygenated. But all of that has gone awry because I've lost filtration and tubular reabsorption and secretion. And that's really reabsorption into the blood. So most kidney damage caused by renal perfusion problems, when we're talking about the ICU, either pre-renal, meaning glomerulus, or tubular, which is intrarenal. Pre-renal for me is just like unstable angina. You don't come into the ED. You don't come into the ED with acute 10 out of 10 chest pain that is induced by movement and relieved by rest, and it's the first time you've ever had it, without us actually evaluating what's occurring. So pre-renal failures, like unstable angina, it's giving you a warning. Your kidney is hypoperfused and it's ischemic. Lots of toxins are mediated, hyperinflammation cascades are initiated. And then you go from pre-renal, if we don't pay attention to that and we don't resuscitate the kidney, we end up in the sustained ischemia, just like a myocardial infarct. Now we've damaged the mitochondria in the kidney. They produce oxyradicals, which then cause further damage. They consume all of the stored energy. That's the ATP. 5 minutes of ischemia. You've consumed 90% of your ATP and you're not replacing it because you don't have oxygen delivery that's appropriate. You're going to infarct your kidney. So from angina to infarct, pre-renal to tubular ischemia, same thing. Now, the first thing is to remember that decreasing urine output, which also correlates to a decreased GFR, is not necessarily always kidney injury, because in the first few minutes, it's a renal preservation. It's a kidney preservation, but sustained reduction in filtration, which then leads to glomerular dysfunction and tubular dysfunction, happens over 20, 30, 40 minutes of time. But urine output alone is not a great indicator. Don't take that as an excuse not to measure it every single hour, to look at the average over 6 hours or the average over 8 hours. That's going to be really important for us when we're trying to evaluate what's occurring with our kidney. Now, what happens in AKI, typically, our patient will be hyperkalemic. They're not wasting potassium because they have acute kidney injury. They're retaining potassium. They're also not wasting metabolic acid. They're retaining metabolic acid. That metabolic acid shifts into the cell. Potassium shifts out of the cell, causing the potassium to go up extraordinarily high over time to 6, 6.5, 7, 7.5. Also with hyperphosphatemia, very important. Hyperphosphatemia is very common when we're looking at cellular lysis, any form of cell lysis, not just rhabdomyolysis. You release potassium, you release phosphorus, and that ends up leading to a high K and a high phosphorus. Hyperphosphatemia in and of itself is not indicative of kidney injury, but it's something that we often will see with kidney injury. But once your kidneys are significantly injured, you then end up having hypophosphatemia. Okay. Advanced kidney failure from any etiology is going to present with those above issues, but it's also going to fail to activate vitamin D. Vitamin D is going to affect your calcium, which you need, of course, for depolarization, repolarization, and contraction and vascular tone. And phosphate regulation, you need phosphate because it is the building block of all energy. So this is a really important concept because this is one of the ways that it affects other things. So this is a very straightforward chart, very straightforward, just talking about how we can basically look at our patients. If we have a good evaluation of our patient and they have pre-renal condition, BUN goes up aggressively, creatinine goes up mildly, but the ratio BUN divided by creatinine or BUN to creatinine is greater than 20-1. That indicates pre-renal failure. If you give your patient a furosemide Lasix stress test, they will increase their urine output. Wow, that's fabulous. If they make urine when you give them Lasix, you actually still have intact tubular function, which means act now to protect the tubes. Act now to protect the tubes. Other things that are important are things about fractional excretion of urea, urea in the serum to urea in the blood, sodium in the serum to sodium in the blood, urine sodium, the amount of sodium in your urine, and the urine concentration. With prerenal dysfunction, you're going to have very concentrated and sparse urine, a high specific gravity, but a low urine sodium. Okay, that's prerenal. But most importantly, my friends, they respond to Lasix by making urine, and they have a BUN creatinine ratio of greater than 20-1. If they have tubular injury and impaired tubular function, they don't respond to furosemide stress test. You give them Lasix, they don't make urine. You give them more Lasix, they don't make urine. You give them more Lasix, they don't make urine. Okay, stop giving Lasix. They're not making urine. They need renal replacement therapy, and they need it now, not 2 days from now. Not when everybody's done with rounds and they come back and hem and haw and talk about putting in a VAS cath. Come on. If my patient wasn't breathing or his PO2 was 30, you wouldn't hesitate to intubate. You'd come off rounds and you'd intubate. I've got a person with kidney injury, and I know that because the BUN to creatinine ratio is high, because when you gave Lasix, they made urine, they still have tubular function. And I want to preserve that tubular function because that is the best bet for that patient long-term to actually preserve their kidney function. So once your tubules are involved, you're going to make small amounts of urine, and it's got a lot of cellular products in it. So it looks concentrated, but when you measure the concentration, the urine is dilute. Urine osmosis is low, and there's lots of sodium in the urine because sodium reabsorption is a function of the tubules. Well, you've infarcted your tubules, so this is quite bad. Typically, the BUN to creatinine ratio is that the creatinine now has gone up aggressively, and the proportional ratio is less than 10-1. So here's the thing that I'm saying to you, like, just stop assuming that your physicians are really looking at the labs. You have to look at the labs. And you might not be a lab guru. I'm not a lab guru. I know small things. I know what I know. But what I do know is that I'm going to look at what my BUN to creatinine ratio is. If I have urine lights, and I should never send a urinalysis on somebody that I'm worried about kidney injury without urine lights, in pre-renal dysfunction, urine sodium less than 20 and the BUN creatinine ratio greater than 20-1. And if I give them Lasix, they will make urine. Their tubules are intact. Now, if I keep giving them Lasix, I'm going to infarct their tubules ultimately because they're going to become dehydrated. So I have to actually step back and say, what can I do to improve arterial volume? Do they need an inotrope? Do they need inotrope plus volume? Do they need a mild vasoconstrictor plus volume plus inotrope? There's not really one answer. There's multiple answers, and it's a yin and yang. I'm going to apply these therapies and evaluate, does my patient respond? Does his BUN go down? Does his urine output go up? That's what I'm looking for. I want your BUN down, your urine output up. That's what I'm doing when I see that you have pre-renal dysfunction. That's not going to work here once you've infarcted your tubules. Once you've infarcted the tubules, you're going to try to protect the remaining kidney from becoming dysfunctional. But my friends, you've already lost some tubular function. So really, really, really important. Once the tubules are injured, creatinine secretion and urea reabsorption is impaired. So the BUN doesn't rise nearly as aggressively as the creatinine rises. And as the tubules are injured, sodium reabsorption is impaired. So urine sodium is high and serum sodium tends to be low because I'm wasting salt and I'm failing to waste creatinine. Okay, so when we talk about defining AKI, there really is a methodology to our madness. It's the KDIGO guidelines for acute kidney injury, the acute kidney injury network, and the renal rifle criteria, which is renal risk, injury, failure, loss, and end stage. AKI defined by this: increase in serum creatinine by 0.3 within 48 hours. Increase in serum creatinine to 1.5 times the baseline, or 50%. Within the next 7 days or the past 7 days. And the urine volume less than 0.5 mLs per kg per hour for 6 hours. But what we think is going to be in the 2024 guideline updates haven't been released yet, and I'm not privileged to be on that committee, so I can't tell you for certain, is that they're going to ask us to consider 3 things. That's an estimated GFR, the patient's serum creatinine, and another functional marker. That functional marker, your lab is already able to do that. It's basically done with an ELISA test, and it's known as cystatin C. Cystatin C is a predictor of renal injury, and it goes up early in acute kidney injury, much earlier than serum creatinine. So that's just something to investigate at your hospital. Is that something that can be done? And when we're looking at patients who are at renal risk, this is what we want to look at in prediction quality for renal risk. It's not a full-time staging for tubular dysfunction. It really is about renal risk. So again, we look at staging, we look at AKI. We don't say, it's very hard for me. I've been around a long time. I always intersperse renal and kidney. We really don't say renal anymore. We always talk about kidney. AKI, CKRT instead of CRRT, CKRT, replacing kidney. And we talk about AKI staging, which is related to the evolution of the increasing creatinine and how that correlates to our patient's acute kidney injury. And we want to remember, just like unstable angina, acute coronary syndrome, non-STEMI, STEMI. So let me say it this way: unstable angina, non-STEMI, STEMI. It's a syndrome. It's a spectrum. Pre-renal to tubular necrosis. It's a spectrum. And our goal, just like with myocardial infarct, is to evaluate you with unstable angina or non-STEMI before you have STEMI. With the kidney, we want to recognize pre-renal dysfunction before you infarct your tubules. That makes perfect sense. So this is a fantastic visual that I downloaded from Core Internal Medicine. I love how it looks at this. It just reminds us that we don't have a great biomarker for the kidney. We'll talk a bit more about that in a moment. Creatinine is what we classically look at. Creatinine is freely filtered. It is not reabsorbed. It is a bit secreted by when you have early kidney disease, chronic kidney disease, and by certain medications that we utilize, like Bactrim and other antibiotics and salicylates. So it's affected by high or low muscle mass. So very, very skinny people won't really spill much creatinine. People who are very muscular are going to spill more creatinine. And it's not highly affected by non-kidney disease. Cystatin C, which basically is not really that new, it's been around for a while, but it's freely filtered, it's not reabsorbed, it's not secreted, it's not affected by muscle mass, which makes it much more likely to be a better predictor of acute kidney injury because it's not affected by those other things, which is certain drugs, chronic kidney disease, high or low muscle mass, all affecting creatinine. This does not get affected that way. But what I want you to remember is that the kidney communicates to every organ. So once I have acute kidney injury, I start having fluid retention, I release cellular debris, I have an abnormal acid-base balance, I am erred on the side of metabolic acidosis, and this fluid overload affects my lungs, producing or worsening ARDS. And this fluid overload puts my cardiac system at risk, worsening heart failure and volume deficits. The fluid overload affects the liver. The fluid overload affects my intestinal microbiota, and the fluid overload affects my cerebral integrity. So first and foremost, the fluid overload is going to encourage all these other organs in dysfunction. But it's also really important to remember that the inflammatory mediators that are released with kidney injury are also going to communicate through the blood to all these other organs. Once you have acute kidney injury, everything else is going to follow along. It's either going to be, you may have ARDS, which then promoted acute kidney injury, and now the acute kidney injury is making the ARDS worse. You may have had heart failure, which promoted acute kidney injury. Now you've got acute kidney injury, and that's making the heart failure worse. This is a very synergistic partnership with every single organ. But most people don't really talk about or think about the kidney in this way and how meaningful it is. Now, one of the most important issues is that we love to give volume when we suspect the patients have sepsis, which is great. But aggressive fluid resuscitation may not really improve microvascular oxygenation, doesn't really improve oxygen delivery, right? Cardiac support, packed cell resuscitation, whole blood resuscitation will affect microvascular oxygenation. Just giving fluid doesn't necessarily improve that. Giving fluid deteriorates our cells, and it causes that interstitial edema. As soon as you start seeing interstitial edema, remember that the arteries are now compressed. This is compartment syndrome. So as you have interstitial fluid exacerbation, you're now compressing your arteries, and that's going to further exacerbate dysfunction. Fluid overload very significantly. Positive fluid balance actually worsens ARDS. And it also, if you don't have ARDS, it's going to prolong your time on the ventilator and your ICU stay. Fluid overload leads to something vitally and profoundly important in terms of recognizing what's happening with your patients, and that is central venous congestion. So that means looking at the neck veins if you've got ultrasound, but also correlating the CVP if you have a triple lumen from the brown lumen of the triple lumen. I'm not asking anybody's permission to monitor that. They don't have to give me permission. I'm going to monitor it. If they choose not to listen to what the CVP is or understand what the CVP is showing, I am going to try to change their minds and their knowledge about those things. But in the end, you don't write the orders. Your physicians or your providers write the order, your APPs. But we have an obligation to assure that we're reporting data scientifically to help drive the practice for our patients. So number one, and what most critical care nephrologists consider to be the most important attribute that we see that worsens kidney function and that is highly expressed with kidney injury is venous congestion. Okay. So again, that fluid overload state can cause a very significant reduction in cardiac function, impairing that with fluid overload, thereby decreasing your MAP and your blood flow dynamic. The acidosis that has occurred is now causing loss of vascular tone. And many, many, many patients, when you look at the chest x-ray, they look like they have ARDS, but it really is secondary fluid overload. And they'll get better once you remove fluid with dialysis or CRRT. Okay, so now we think about venous congestion as being a major factor here, along with the reduction in arterial blood flow. So I know those of you who've heard me speak before, have seen me speak before, have come to talks that I do. This is a very common visual that I use. I want to remind you that the LV ejection, the vascular tone, is what determines your systemic arterial pressure, in particular systole. That the mean arterial pressure is the average between the depth and the height of your blood pressure, and the average of those pressures and the time that they exist for the patient. Like my systolic pressure is 1/3 of the cycle, my diastolic pressure is 2/3 of the cycle, and that affects the overall average pressure, which is ultimately driving blood flow to the terminal point, from the artery to the capillary to the venule to the right atrium. Terminal point being the right atrium, and that's where you measure the CVP. So really important for us to appreciate MAP, stroke volume, or echocardiogram are going to tell us about forward flow. And I have to have forward flow. I have to have forward volume, and I have to have forward pressure. CVP is telling me about the resistance or the venous congestion that's been enabled in the systemic venous compartment, most particularly in the right atrium and right ventricle. So CVP is really the resistance to the MAP. And what that really tells me about is the impact on kidney injury. Raised CVP has much greater impact on acute kidney injury progression than MAP. But more importantly, going to think about what we call the systemic perfusion pressure. Now, that might be something new for most of your colleagues, and they're probably not going to completely say, oh, you're so brilliant. Thank you for attending a class and giving me this information. They're going to say, what the heck is that? You attend too many conferences. What does that mean? But MAP minus CVP is your systemic perfusion pressure. MAP minus ICP is cerebral perfusion pressure. MAP minus CVP is the systemic perfusion pressure. And I need that to always be above 65. So if my CVP is 25 and my MAP is 50, I don't have perfusion pressure. I'm going to have engorgement of volume in my veins. That venous engorgement is going to put my kidney further at risk. And this is really quite worrisome for our patient. The idea here is rapid decongestion. You're going to get Lasix, you're going to get a second Lasix, you might get a third Lasix, and then I'm going to talk about CRRT. And I'm going to do that early. I'm going to do that soon. I'm going to do that because I cannot maintain an MAP CVP gradient. I can't get your MAP up. I can't get your CVP down. You've got interstitial volume that's compressing the arteries, and distal to those arteries, I have no blood flow, and I have evolving, worsening lactic acidosis. So my goal is that I want to increase renal blood flow. I want to reduce renal congestion. I want to reduce my venous pressure. I want to reduce my interstitial pressure. And the only way that I can really do that is by removing or by setting up a methodology to ultimately remove interstitial volume. Okay, so if you just take a look at this patient, this is a patient that we took care of in our ICU. Her MAP is 60, her CVP is 19, 60 minus 19, 41. Everybody was pretty happy with that MAP. But not me. I'm not happy. CVP doesn't tell me about volume. CVP tells me about failure for volume to mobilize. And when volume doesn't mobilize, it congests your veins. And when it congests your veins, it congests your liver, your kidney, your spleen, your mesenteric bed. But most importantly, the one organ that can help me regulate volume is going to be profoundly impacted when your CVP is high. Excuse me, I'm just going to get a cough drop because I've been talking all day teaching basic CRT today. So you think this is my first hour of talking. This is my 9th hour of talking. My voice, I'm losing it. So sorry. So again, we've got reduction in arterial blood flow, and we've got a representation of venous congestion. And you can just look at the monitor and already know that. So I want you to remember this. Acute kidney injury is a syndrome. It's not a singular event. We see acute kidney injury and acute kidney failure as traditionally as a single disease. It's not. It's a complex constellation of interactions with every important organ in the human body: the lung, the heart, the liver, the gut, and the brain. And it isn't just volume. It's uremic toxin, it's hyperinflammatory cascading, it's hormonal dysregulation, it's interstitial edema that is compressing the arteries, promoting compartment syndrome, and failure of blood flow dynamic. The context of kidney injury is absolutely essential because the number one context that we can try to intervene in is prerenal kidney injury. Heart failure, volume depletion, sepsis. Do not give up until you have restored arterial volume. And one of the most important things about restoration of arterial volume, you're going to start to clear BUN, you're going to start to clear creatinine, your GFR goes up, your urine output goes up. These are all important components. Your CVP goes down, your MAP goes up. These are all important components. I'm going to end really with just this perspective about I talked so long, I'm so sorry, about the old face for recognizing kidney injury, and that is serum creatinine. We know that serum creatinine does not evolve aggressively enough and early enough to tell us that you have AKI. So I always like to show this. In the 1960s, we evaluated acute myocardial infarction by LDH. I started practice in the mid-1970s at Mass General, and we were looking at CK and myoglobin. But by the 1980s, we were looking at CK and B as more specific to cardiac cellular structure. Then to troponin T in the 90s, troponin I in the 2000s, and in 2015 to HS troponin. So you can see there's been a lot of variation, which overall has defined our therapeutic approach, has defined our early evaluation of patients, the rapidity of getting them to the cath lab and opening their arteries, and has reduced mortality by 50%. In the 1960s, 70s, 80s, 90s, 2000, and 2015, we still look at serum creatinine. Why is that? Nobody put money into acute kidney injury. That's why. I mean, that's just the truth. So now what we're using is serum creatinine to tell us about how to support the kidney once it's already injured. So that's why we have such high mortality. But for the future, we're going to see biomarkers. And in biomarkers, there are already a lot of biomarkers available. The problem with biomarkers is it depends on what stage you're in, the evidence of that biomarker. The biomarker tells us about structural kidney cell loss, the internal contents of those kidney cells. But throughout the kidney, there are different cell groups that are going to lose different internal contents. And the problem with biomarkers right now is that everybody would like one biomarker, like creatinine or like troponin, HS troponin. But when we're talking about the kidney, each course and every individual patient on their trajectory are going to have different biomarkers that tell you where they are. So in the new phase of measurement, we're going to have a lot of different biomarkers that are really significant related to the degree of activation and the amount of time that the patient's been in kidney injury. And if you've already been in injury for 6 hours, I'm going to have to look at some different biomarkers than I would have looked at really early on, because different structures in the kidney are being affected by the failure of blood flow, by the failure of blood pressure, and by the failure of oxygenation. So last but not least, one of the most fantastic presentations in 2020. Now, this was in pediatrics, but using an external infrared spectroscopy to look at renal tissue oxygenation. So correlated with that, so utilizing methodologies like what if you have hemosphere, you could look at StO2 and you could apply that looking at renal oxygen to have a better idea about blood flow and oxygen delivery to the kidney. And that's going to give you a lot more help. This is just one study. It's small and it's in preterm neonates. So many folks are looking at methodologies of evaluating renal oxygen to actually be a predictor of patients who are at risk for losing tubular function and targeting the therapeutic intervention to increase the oxygen delivery to the kidney and reduce the infarction of the tubules. Also, more and more specific biomarkers. Some of you worked with NGAL. Some of you have worked with NephroCheck, which looked at 2 different biomarkers. But the problem with the biomarkers that we currently have is we're just not sure where they focus on the stage of kidney injury, and that makes them a little bit less relevant. But stay tuned. In the next 5 years, we're going to have an abundance of biomarkers. I believe we're going to have targeted resuscitation and precision-based medicine that really helps us to employ a better methodology to protect the kidney from the most common injurious event that happens in the ICU, pre-renal failure, pre-kidney failure. Today, focus on persistent and refractory metabolic acidosis that also causes persistent and refractory hypotension. Focus on the GFR and focus on how the GFR responds when you give volume, when you give inotrope, when you give a vasopressor. Focus on the serum creatinine. Remember, just 0.3 milligrams per deciliter increase in the first 48 hours tells you you have kidney injury. Focus on urine output in mLs per kilogram per hour. Focus on your patient's body weight, because if they're gaining weight, that's from fluid. Focus on that CVP and venous congestion. And remember, MAP alone is not enough. MAP plus CVP, I shouldn't have said it that way, I'm so sorry. MAP minus CVP, which gives me the perfusion gradient, can really help me define a better trajectory to help protect my patients' kidneys and to improve outcomes for the patients who come under my care and who trust me with their organs. I hope this has been meaningful to you. I'm so grateful whenever you are willing to spend time with me. Hope I'm going to see you tomorrow. Tomorrow, the long-awaited perfusion, posterior infarct, which I was meant to do 2 weeks ago, got stuck on a flight that was delayed, wasn't able to do it. So thank you very much, everyone, for joining. Thank you for the incredible work you're doing every day to keep patients alive, to educate and support each other, and to support patients and families. I'm so grateful to be part of this career and this profession, and I so appreciate everything that you do. I'm going to stop my recording, but I will be available for questions after. Thanks so much. Bye-bye for now. Just stop my recording.